Hi, I'm Dr. John Emil Kenny again, and this is Chapter 4 entitled Heart-Lung Interactions in Sickness. So Chapter 4 is going to be broken down into various disease states, and we're going to specifically look at heart-lung interactions in these various cardiopulmonary maladies. Let's see. Again, I talked a little bit about this in Chapter 3, but what I present in my slides in each disease state is not dogmatic. It's not like every COPD exacerbation or every heart failure exacerbation is presenting exactly with the physiologies that I'm illustrating with my slides. These are simply meant to be, potential mechanisms at play in each of these disease states and things to consider when you're thinking about pulse pressure variation and collapse of the IVC and biventricular loading conditions when patients have abnormalities of airways resistance, lung and chest wall compliance, and how that affects venous return and cardiac function. So again, it's not, nobody's figured out exactly what happens in every patient in terms of their cardiovascular status in response to changes in intrathoracic pressure and volume. And that's, I think, sort of what makes this stuff kind of fun, is that it's always a little bit of it's a little bit of guesswork, but it requires an understanding and an educated approach. So we spent the last chapter, Chapter 3, discussing heart-lung interactions in health, and now we're going to shift this to certain disease states. And again, it'll be via the simultaneous analysis of both Campbell and Guyton diagrams. So, like the Venn diagram we considered in Chapter 3, the major mechanical effects of the respiratory system upon cardiovascular systems, changes in lung volume, changes in intrathoracic pressure. And again, I'm really essentially ignoring, which is, maybe a little bit of an oversimplification. I'm ignoring neurohormonal effects. I'm ignoring sympathetic effects that occur during these disease states. But again, the point of my entire website is to focus on these classic mechanical interactions and pressures and flows and volumes. And just a reminder, the Campbell diagram in Chapter 1 we talk a lot about. It depicts lung volume and intrathoracic pressure as a function of lung and chest wall compliance. Again, intrathoracic pressure or pleural pressure will be on the x-axis, and volume will be on the y-axis, or in the three-dimensional analysis that I present on the z-axis going into the page. So the respiratory system can affect the cardiovascular system not just by these mechanical interactions, but also by the work of breathing and oxygen costs. So this is me not completely ignoring some of the chemical or biomolecular interactions between these two systems, and I think it's worth talking about this at the outset of this chapter, which I'll get into in the next couple slides. The cardiovascular system can also affect the respiratory system, and again, I'm trying to explore these mechanical interactions, but as I mentioned, neurohumoral and biochemical relationships certainly are at play. Left heart filling, as we talk about in Chapter 5, I believe, in the physiology of extubation failure. Certainly, left ventricular end diastolic pressure can feed back and alter pulmonary airways resistance, pulmonary compliance. You can get pleural effusions, chest wall edema. All these things can affect chest wall compliance as well. So there can be a vicious cycle. What am I saying here? Yeah, that's about it. Trying to highlight these basic principles of heart-lung interaction. So as I mentioned, we're going to start off the beginning of Chapter 4 with this notion of ventilation as exercise. So I dedicate an entire portion of Chapter 1 to this idea of work of breathing, and you can get a graphical estimation of work of breathing, both in terms of dynamic work of breathing and elastic work of breathing from the Campbell diagram. So this is the it's the elastic and resistive work. Elastic work is stored as potential energy, and you estimate this from the static elastance curve from the Campbell analysis. And we often ignore some of the work effects that are required to that's resistance. The elastic work is the amount of pressure that's dedicated to affecting lung and chest wall volume change, whereas resistive work is what I was trying to say, is dissipated as heat. And when we think of resistive work, we almost invariably think of the work required to drive gas flow. But the forgotten resistance is this idea of tissue resistance, which is energy that's dissipated as heat, just that occurs as tissue slides over itself. And this is usually a very small portion of resistive work. So just breaking this down graphically, work of breathing, you can think of in terms of elastic work of breathing. And again, when you're approaching a patient at the bedside, or you're approaching an arterial blood gas analysis, and you're thinking of, for instance, why a patient might be retaining carbon dioxide, well, you can think of it in terms of elastic and resistive work of breathing, because both of these can impair ventilation and drive up your carbon dioxide levels in your blood. So the elastic work of breathing is broken down into lung elastance and chest wall elastance, which you can get nicely from the Campbell analysis, but also resistive work of breathing, which we typically think of in terms of the pressure that must be applied to overcome the inertia between the gas molecules, so you can drive gas flow, but also this tissue resistance, which is say for instance the visceral pleura of the lungs sliding over the parietal pleura of the chest wall. So this is the Campbell diagram that depicts the work of breathing. In terms of, it breaks it down into dynamic work as depicted on as the red shaded arrow in the Campbell analysis, and the elastic work as the blue shaded region, this triangle here. And then this gray-black portion is a portion of work that you actually reclaim during inspiration, because this work is actually used to collapse the chest wall from its equilibrium volume up here down to FRC. So it's sort of like spring loading the chest wall in a way. So then as the chest wall increases in volume, it tends to do so just to reach its own equilibrium volume. So that work is actually reclaimed as you increase lung volume. So just to reiterate, this is the work required to overcome the resistance of the respiratory system. And so the total work performed by the inspiratory muscles is the blue shaded area, which is the static work, plus the red shaded area, which is the dynamic work. And if there's active expiration, the work performed to overcome the flow resistive work here on expiration would be highlighted. I don't have it colored in here, but it would be highlighted by this loop to the left of the chest wall elastance curve depicted here. So that would be additional work of breathing if the patient were forcing out an expiration. So almost all of you listening to this lecture have probably seen this as a patient's trying to achieve adequate expiratory flow. When they're in extremis, they grunt and bear down and try and force out that breath, and that results in high intrathoracic pressures in order to drive out that breath. So what's this idea of oxygen cost of breathing? Well, if you look at oxygen utilization here on the y-axis in terms of as measured by the V.02, so V.02 is just what it is. It's as labeled as your oxygen utilization. This depicts normals, and as you increase your minute ventilation, say as somebody's exercising, you see that the V.02 tends to increase in a somewhat exponential fashion. And then just as an example, if you look at patients with emphysema, the curve it almost goes straight up, and it just requires very small increments in minute ventilation before there's very large increases in the V.02. And the reason that occurs in emphysema in particular is that we talk a lot about this in Chapter 5 actually. There's this dynamic hyperinflation, so there's There's a decrease in lung and chest wall compliance, so an increased amount of work goes into changing your lung volume. There's this intrinsic PEEP, that this threshold load that is applied essentially to the alveolus that must be overcome by inspiratory muscle tone to drive airflow. There's tonic inspiratory activity, poor mechanical efficiency of the muscles, the diaphragms flatten out, so you lose that nice curvature, and your efficiency of your diaphragmatic muscles is lost. You recruit other muscles, the latissimus dorsi, the strap muscles of the neck. All of these are increased. They undergo increased work during inspiration to really drive up that V.O2. So this is a surrogate for work of breathing. For a given tidal volume, the work of breathing increases for emphysema. And you can apply it for somewhat similar reasons to other respiratory disease states that we're going to talk about in this chapter as well. And in order to maintain this degree of oxygen utilization, as you can imagine, the cardiac output must increase greatly to increase oxygen delivery. And I talk a little bit about oxygen delivery and oxygen kinetics in Chapter 7 when I talk about the physiology of using FIC to calculate cardiac output. And this is an often quoted number, but the muscles of respiration, the muscles of respiration, I should say, can increase their blood flow by 5 to 6 times during states of respiratory distress, and this imposes not a mechanical stress upon the cardiovascular system, but certainly this will perturb the physiology to a great extent, and this is simply a result of changes in oxygen kinetics. And this may be part of the reason why transition from mechanical ventilation to spontaneous ventilation can fail, and we talk quite a bit about this in chapter 5. So that's really a very quick overview of ventilation as exercise and how the muscles of respiration will require a greater degree of blood flow during respiratory distress, and how that can certainly stress the cardiovascular system. And really, the rest of this lecture and the rest of the other chapters deal a little bit more, or almost completely, focus on how mechanical interactions between the respiratory system and the cardiovascular system exert stress on each other. Thanks. Stay tuned.